Next, Peter McCollugh is joined by Dr. Jeffrey Weitz, Professor of Medicine and Biochemistry at the McMaster's University in Hamilton, Ontario, Canada. They discuss, is there a role for warfarin in the management of DVT in 2014? Clinical dilemmas in venous thromboembolism. What every cardiovascular provider needs to know.
I want to start by welcoming you to ACCEL.
Well, thank you.
We've all been excited about the introduction and now the use of novel anticoagulant agents that don't require monitoring. Many are thinking that the days are numbered for warfarin in the management of venous thromboembolism, or VTE. I wanted to get your insights today kind of in two populations, incident cases and then prevalent cases where you think warfarin still has a role. So why don't we start out with the incident case, so the new case of a deep venous thrombosis or a pulmonary embolism, typically we diagnose in the emergency room.
For the incident cases of VTE, the conventional treatment would be to start with a parenteral anticoagulant, usually low molecular weight heparin, and transition them to warfarin. Now, as you said, we have NOACs right now. Rivaroxaban is the only one that's licensed for VTE treatment. But in the next few months, I would expect that we're going to have other ones licensed for this indication. And there's even the potential to go all oral with rivaroxaban or apixaban, which really can expedite the transition of care. But there are certain VTE patients where the oral agents would not be indicated. So for patients who come in with massive or submassive pulmonary embolism or very extensive DVT, who might be candidates for advanced therapies like lytic therapy for their PE or pharmacomechanical therapy for their DVT, those patients should get heparin because you can adjust the dose and titrate it, you can turn it off, and we have a lot of information about its adjunctive use in the setting of lytic therapy. We have no information about the use of the new agents. Likewise, a patient who, say, develops a VTE event soon after major surgery and you're really worried about a high risk of initial bleeding, those patients might be better off with a heparin infusion because you can turn it off, it goes away quickly, and you can even give protamine sulfate for reversal. Patients who have renal impairment, so patients who have a creatinine clearance below 30 mLs per minute, they're not candidates for the new agents. They're going to continue to be treated with warfarin. The new agents are also contraindicated in patients who have liver disease, as evidenced by a baseline prolongation of the PT, the prothrombin time, or the INR. Now, those patients are difficult to manage on warfarin, but again, because all of the new agents are metabolized through the liver, they could be problematic in those patients. And finally, patients may not be able to afford the new drugs. They're more expensive. So then they might be better candidates for conventional therapy. And patients might not be, you might be worried about compliance. And so for unmonitored therapy, you might be worried, but at least with warfarin, you know where they're at. You can monitor the level of anticoagulation and you can keep track of whether they're taking the drug or not. So those are some examples of the incident cases of VTE where conventional treatment, including warfarin, might still find a role. Then we have the prevalent cases, so the patients who have VTE and they're usually on warfarin. Which patients should stay on warfarin? Clearly, the patient who's got an erratic INR on warfarin would be a good candidate for the new agent, but those who are perfectly stable on warfarin and they're not having any complications, unless they want to switch, I don't see any point in switching those patients to a new agent. And those are examples of how warfarin is going to continue to remain in the armamentarium of drugs that we use to treat VTE, even as we move forward and more new agents come on the market.
Well, that was an extremely helpful review. And I think with respect to the incident cases, what I learned is if we do an intervention, we give a lytic agent, we do a mechanical or catheter-based intervention, ultimately that transition probably should be to warfarin. Would you agree with that?
Not necessarily. If we do an intervention and the patient is stable now, I think then you can discuss with the patient whether they want to go on warfarin or want to go on the new agent. So once they're stable, there's no reason why you couldn't transition them to a new agent. Mm-hmm. But during that very initial place, you don't want to have them on the new agent.
I got it.
But once they're stable, you do have a choice of going to the new agent or to warfarin.
Okay. How about a couple more scenarios? Patients frequently get some form of systemic anticoagulation, in a sense, prophylaxis for VTE in the setting of hip and knee surgery. What about patients who actually turn out to develop the thrombus despite the prophylaxis?
Well, I think that after hip or knee surgery, most patients are getting anticoagulant prophylaxis. It might be with low molecular weight heparin. It might be with one of the new agents. Both rivaroxaban and apixaban are licensed in the United States for postoperative thromboprophylaxis. And I think that if they do have breakthrough thrombosis, your choices are they're on the low molecular weight heparin, to bump the dose of low molecular weight heparin up to a treatment dose and transition them to warfarin. Or if they're on rivaroxaban or apixaban isn't licensed for VTE treatment yet, but if they're on rivaroxaban, for example, you could go from the prophylactic dose to the treatment dose.
Okay.
But you have to be a little bit careful about how far they are after the surgery because of the risk of bleeding. And so if you're worried about that, you might want to go with conventional low molecular weight heparin, at least for a few days, make sure that they're okay, and then transition them. But those are considerations. I guess one other point with the incident cases of VTE that we should mention is that these clinical trials with the new agents did not include patients with major thrombophilias. So, for example, if patients have antiphospholipid antibody syndrome and they have thrombotic complications and you're thinking about treatment, we have no data on the new agents. It's not that they don't work, we just don't know that they work, or some of the unusual thrombophilias. So those are rare patients, but they are patients where you might consider conventional treatment as opposed to the new agents.
How about the circumstance if we have a patient in the office and they have as one of their problems a malignancy, and they come in with a swollen leg and the clinical diagnosis is a DVT, but they haven't had a PE and it's not a particularly large DVT, what's the way to go there?
So for cancer patients with thrombosis, the usual route is to give continued low molecular weight heparin as opposed to transitioning them from low molecular weight heparin to warfarin. Warfarin is problematic in the cancer patients. A lot of cancer patients are getting chemotherapy, radiation therapy, biologic agents. They may have GI disturbances. They may have hepatic metastases. They may need interventions. Warfarin is very problematic. So low molecular weight heparin is probably the treatment of choice. And although some cancer patients were included in the trials with the new agents, if we think of all the trials that were done, there's only about 1,000 patients with cancer in all of the trials. So we need more information on cancer patients. We need to know how the new agents compare with low molecular weight heparin in that population. So there's still more information to be gained from that group.
Okay. And Jeff, in the clinical trials of the newer agents, when a patient who was randomized to one of the novel agents did in fact have a VTE, let's say a VTE event, or clinically manifest another VTE, what happened?
So if they did have a recurrent event, and that was an endpoint in the study, but then they would be managed with conventional therapy at that point, because in the times of the trials, we didn't know what was working. So
So assume that was warfarin in most of these studies.
It would be low molecular weight heparin followed by warfarin.
Right. Would that be your advice now if a clinician in practice has a patient, let's say on rivaroxaban, and they're 3 months into treatment for a DVT PE, and they have another PE event on the drug?
Yeah, I think that if they did have that scenario, again, the first thing you'd want to know, are they taking the rivaroxaban? But if they were and they had it, I would be inclined to treat that patient like I would a patient who was on warfarin and had breakthrough thrombosis as kind of a warfarin failure. I'd consider them a rivaroxaban failure. And then what I would do is I'd put them on low molecular weight heparin for a period of time and then consider transitioning them back to an oral agent. But I'd use low molecular weight heparin for a period of time. It may be even a month or longer. And then I'd consider, am I going to transition them back to rivaroxaban, or will I transition them to warfarin? And then I can really monitor their level of anticoagulation.
Okay, terrific. Well, that has been a great review of the scenarios, both in the incident cases and prevalent cases of VTE, where cardiologists could become involved. We know the use of novel agents is very common in the community, And I think what you've helped us understand is really the current role of warfarin and also, very importantly, low molecular weight heparin and in some cases unfractionated heparin in our kind of global armamentarium for VTE. Do you have any final words for the ACCEL audience?
Although the new agents are really revolutionizing the management of thrombotic diseases, you have to use them in the right dose for the right patient. And there are still going to be patients, whether they're patients with atrial fibrillation or patients with venous thromboembolism, who are going to be candidates for conventional therapy. So warfarin is going to stay for some time. And you know from the cardiology perspective that, for example, patients with mechanical heart valves, we can't use the new agents. We're going to be stuck with warfarin for some time to come.
Well, let that be the last word, and thank you for joining us on ACCEL.
Well, thank you.